To start with the scientific ground, Dr. Karthikeyan is Community and Family Medicine PG, AIIMS Patna, State General Secretary of IMAJD in Tamil Nadu. Over to you, sir, for the next proceedings.
Thank you so much, Evalina. Very good evening, everyone. As she mentioned, I'm Dr. Venkatesh Karthikeyan, Community and Family Medicine Postgraduate Resident from AIIMS Patna. I'm glad to know that more than 250 doctors from lengths and breadths of the country have registered in today's webinar. The World Health Organization has revealed that there are around 200 cases of monkeypox, and a lot of suspected cases are there in 19 countries. Experts describe the events as random but containable. But however, there is a lot to know about the virus and its potential to turn out as a threat. Nevertheless, with the world still reeling from the effects of the COVID pandemic, the rise of this monkeypox is putting many people on edge. Yesterday, I came across an article mentioning that the monkeypox has been found in people with no direct travel link to endemic areas, which represents a highly unusual event. So, a lot of confusions and panickings going around. And to give us a better clarity, FAIMA is organizing this panel discussion under the leadership of National President Dr. Rohan Krishnan sir. Also, we have our spokesperson, Dr. Rafia Khan ma'am, along with us today. Now, I request our spokesperson, Dr. Rafia Khan ma'am, to welcome our panelists and introduce them. Over to you, ma'am. Ma'am, you're muted.
Yeah, am I now audible? Thank you, Dr. Venkatesh. Good evening, respected panelists and all my dear colleagues who have joined us for today's session. Despite having a busy schedule, I welcome you all for today's session, which is being organized by Federation of All India Medical Association on the topic, Is Monkeypox the Next Pandemic? My name is Dr. Rafia Khan, and I'm currently the National Spokesperson of Federation of All India Medical Association. I'm pleased to welcome aboard our eminent speakers and guests for the day. Professor Dr. Suresh Kumar, sir, is Director of Lok Nayak Hospital, New Delhi. Also, he is the head of Department of Medicine, Maulana Azad Medical College. I welcome you, sir. I would like to introduce Dr. Media Prati Garg, who besides being consultant physician, is a medico-legal social activist, medical health counselor, and CPR trainer. She is currently the convener of IMA Patient Charter Protection Cell. She is also the former convener of IMA Grievance Cell. She is Vice President and two-time Secretary of IMA New Delhi branch. She has been Medical Director of Heartcare Foundation of India. She is also the founder of NGO like Healing Hands, through which she is providing free health education, moral and social values, especially to children. Also, I would like to introduce Dr. Shaista Ali, who is a public health expert and an ex-resident of Madhubani Medical College. Welcome, Dr. Shaista. Also, I would like to introduce and welcome Dr. Nilakshi Gupta, who is presently working as Senior Resident in Department of Microbiology, Lok Nayak Hospital, New Delhi. I would like to take this opportunity to introduce the moderator for our session today, Dr. Venkatesh, who is a very dynamic and a very hardworking person. Nonetheless, a special thanks to Dr. Rohan Krishnan, President of Federation of All India Medical Association, and also the convener for today's session, for organizing such a webinar on such an important topic like monkeypox and inviting such learned and esteemed guests on board. With this, I would like to hand over Dr. Venkatesh to commence and moderate today's session. Thank you all. Hope you enjoyed this session. Over to you, Venkatesh.
Thank you so much, ma'am. So for the initial half of the session, we'll have a presentation from our esteemed panelists, following which we'll have panel discussion and question and answer. So currently the Zoom platform is used only for the panelists, and the live streaming for the audience is going on Climate platform. We have more than 250 registrations for today's event, and I'm sure this is going to be a great treat for all of us. So without further delay, I request Professor Dr. Suresh Kumar sir to enlighten us on this important topic. Over to you, sir.
Good evening to all of you. First of all, I must congratulate the FAIMA and the team of Dr. Venkatesh and all the leading experts that this is a wonderful topic, and this webinar which you are organizing today is the need of the hour. We have already have many cases all over the world, but we are lucky that India has not reported a single case till date. We have already in the phase of pandemic for last 2 years, the COVID is giving us a very tough time. And we have seen that many of our colleagues, doctors, nurses, they were having great panic in the initial phase of pandemic. When we were dealing the COVID in 2020, the knowledge was very little, and there were a lot of phobia in handling the cases of COVID, and we have no guidelines how to diagnose the disease, how to approach the patients. So similarly, this time, a great new challenge is emerging, and we have seen that this monkeypox is seen in many of the African countries, European countries, and every day new countries reporting the cases. As you have already discussed, there are around 200 cases reported all over the world. But there's a need to have a knowledge to give the latest feedback about how to handle the cases, how to diagnose the cases, what are the challenges we have, and what is the robust mechanism for the surveillance of the cases. So all these aspects we will discuss in next 1 hour, where the clinicians, microbiologists, public health experts, and all the leading scientists will give their views how to handle the new disease, and can this monkeypox be a real next pandemic. But it is very difficult to say because it's very premature that this is as big as the COVID, but we hope that this virus, which is different from the COVID virus, that was the RNA virus, this is DNA virus. So we know that the DNA virus are less disastrous than RNA virus. We have seen in the last many outbreaks in the epidemics that this time this don't create a havoc, and we have the more knowledge about this disease. So can we have the first slide?
Can you please, Debalina, can you please play the first slide? If not, I can project the slides. Okay, I'll project the slides from my side. Sir, is my slides visible, sir?
So dear friends, the monkeypox originally was seen in the African subcontinent, and the first case was reported in the Congo, and this virus is a envelope virus where it was seen in the Africa that it is mainly a zoonotic viral disease, and the human are infected in the close contact, and most of these monkeypox virus cases were seen in many of the African countries, Central Africa and West Africa country, and from there a lot of international travelers were infected in the England, in the various other countries, and where we have seen that more and more cases were reported. Next slide. You can see the structure of this virus. This is a DNA virus where you can see the envelope and you can see the genetic material inside. You have the virions, and you can see that this structure is very much different from other virus, and it can cause the various stage of viral replication, which microbiologists will tell you in more detail, but this is the simple structure where you can understand the viral dynamics. Next. And this is a very simple slide that this monkeypox virus initially seen in the monkeys, and the monkeys were kept for research. And in the Copperham, it was seen that these monkeys have the lesion. And these lesions, when the virus was isolated, it was seen that it is, as the first cases was seen isolated from the monkeys. So the name was given as a monkeypox virus. And this is typically seen in Africa. Those cases primarily where you have the history of bites or scratches, and you have the rodents and the use of bush meat in the African country. This habit is not seen in the Indian subcontinent, but in the Africa, a lot of bush meat consumption is seen, and where these cases of monkeypox virus was first detected. Now, coming to the human-to-human transmission as a secondary transmission, which is also very frequent when you have the close contact with the infected person. So you have the droplet infections, you have the secretions, you have the contact with the blood, you have the contact with the mucous membrane, and even the vertical transmission from mother to child through placenta is also reported. And also you can have the sexual transmission of the disease, because once you have the close contact, sexual contact is one mean of transmission from human to human. Now, coming to the symptoms, the 100% you have the skin lesion, you have 98% cases in the series. We have found that fever and skin rashes, they are two important findings. So all these patients have 100% skin involvement, and up to 90 to 95% cases were having fever. And most of these patients also have the lymph node enlargement, lymphadenopathy. Lymphadenopathy is very typical. That this lymph node enlargement is not seen in other viral disease like chickenpox, in measles, which you can have the differential diagnosis, but this monkey virus involves the lymph node. That is very important. Along with this skin involvement, intense headache, you have the muscle pain, you have the rash mainly on the face area, and you can have the rash all over the body. But the main difference of the skin rashes or skin lesion, it's mainly the maculopapular lesion. And you can have the vesicles, you can have the crust, and these individuals are highly infected. And these typical clinical presentation remains for 2 to 3 weeks. Next. You can see the countries in the African subcontinent. Initially, as I told you, that Congo, Nigeria, Cameroon, and Central African countries, South Sudan, these were reporting the cases. As you all know, that smallpox was eradicated 40 years, 4 decades back, but this is similar to the smallpox, and the skin lesions can be disfiguring, can leave the scar on the skin and on the face. So this is very important to differentiate between the various type of viral disease involving the skin. Next. From Africa, the disease have spread to USA, United Kingdom, Israel, Singapore, and many countries. As we have discussed, that around 20 countries so far reported. The WHO has sounded alert. An emergency meeting was there just 10 days back, and they have alerted all the countries that you must have the preparedness, you must have the surveillance mechanism, you must know the if you have any of these patients from the affected nations traveling, and you know that large number of patients we received during the COVID pandemic, that we had the international travelers from the UK and from the USA. We have the South African variant of COVID, and then we have the UK variant. And similarly, all these patients were isolated at the airports. And still, we have seen that despite of large number of international patients, there is a lot of reporting in the COVID. And similarly, we have the now the emergency meeting of the health department. Most of these states are on alert. The Mumbai has already created a ward and a surveillance center at the Mumbai International Airport. In Delhi, we are also having the meetings how to go about if any case landed in the Delhi International Airport, that how to keep these patients isolated, how to test them, how to approach these patients, and how to diagnose the disease. This is a major challenge in our setup, because lot of these patients are coming from Africa and from the USA and from the Europe also. Next. So, dear friends, you can see that the primary infection from animal to human and secondary infection from human to human. And the mode of transmission I have already discussed, that you have the close family contact, or you have infection from the partner, and you have to be very careful if you have a history of contact with the rodents in the primary infection. This is very important. As I already discussed, vertical transmission from mother to fetus from the placental route is also reported, but are very, very rare. Next. So mode of transmission from the unprotected contact with index case, you can have the droplet infection. Patient can have the pneumonias, viral pneumonias are very common. You can have contact with the skin lesion, and this material can infect you. Body fluids, very, very important source of virus, contaminated materials. And then mucous membranes, eyes, you can see the patient with monkeypox virus have the conjunctivitis, and many of these patients can have the complication in the eyes. Even the blindness is reported with this virus, and broken skin. Next. This is duration. We have the 4 stages. Incubation is 5 to 21 days. Typically, patient have no symptoms, but viremia is there, virus is there in the blood. Next stage is the febrile stage, where patient have fever of around 38 degree, and patients along with fever have the lymphadenopathy. The cervical lymph node, axillary lymph nodes, and the inguinal lymph nodes may be enlarged. Patient can have sore throat. Patient can have extreme fatigueness, and severe intense headache is a typical of this viral disease. And in this stage, patient have virus in the blood, and patient can have the small lesion in the mouth. Oral ulcers can be there. Next. So this is the typical evolution of the skin lesion. You have the maculopapular rash. So initially you have macule, then there's the papule stage, then the vesicles. You can see a vesicular lesion in the palm and in the sole, which are not seen in the chickenpox. Then you have the secondary infection, pustules. There's a pus inside these lesions, and there's a last stage of crust. So there are 5 types of skin lesion which we can see in the monkeypox virus. So once you have the crust stage, then the virus is less, viremia is disappearing, and patient going to the recovery phase. But this crust can leave a scar. You can see the scarring phase, which is very disfiguring. Very important to know the type of skin lesion. So maculopapular rash, which can be further progress to vesicles or pustule. This is very important to identify. Next. Then once you have the skin lesion, we have seen that there is crops of lesion in the different viral disease, but here you have the typical evolution. And once you have the skin lesion, then the patients may recover, and antibodies are there in this stage. Next. This is the recovery final phase, and most of these patients recovers. As per the WHO estimates, that 1 to 10% can have the fatal cases, but most of the series in the Africa have shown that case fatality is 3 to 6%. So the deaths are less, and typically it involves the young generation, young patients, and most of these patients can have the protective antibody later on. Next. So this is the simple slide which shows that you have typical incubation period, last for 5 to 21 days. Then you have febrile stage, and after the fever you have typical rest, with the rest lasts for 2 to 4 weeks, and then after 4 weeks patient recovers. So this is the classical presentation of the monkey virus cases. So if you remember this slide, you can know the clinical profile of most of these cases. Next. So this is just giving you the differential diagnosis, how monkeypox is different from the chickenpox and how we can differentiate from the measles. In the measles and chickenpox, we don't have lymph node enlargement. It's a major difference. So lymphadenopathy is seen in the monkeypox. It is not seen in the chickenpox and rarely seen in the measles. Measles, typically you have the, you will hardly find the crusting lesion. So most of these measles cases are in the children, and measles cases, this is a very mild disease. You have the viral pneumonia can be seen in all, but the measles is typically seen in children. Chickenpox, the main lesion are seen over the trunk, and here in the monkeypox, the lesion are mainly seen on the face and also seen in the palm and soles. This is very important. And death is up to 1 to 10% as per WHO figures. Death is very rare in the chickenpox, and we by this differential diagnosis we can be very clear in the dealing of the chickenpox cases, measles cases, and monkeypox cases. Next. So clinical symptoms we have already discussed. The stages of the disease, very important. You must know that case fatality is 3 to 6%, and transmissions and all we have already discussed. Next. This is a little bit crowded slide, but you should know that the patient of monkeypox can develop secondary complications in the respiratory tract. It can cause severe viral pneumonia. It can cause sepsis. It can cause hypotension. It can cause hypodynamic problems. Patient can have septic shock. In the GI tract, patient can have the disruption in the food intake, and patient can have the dehydration. Patient also can have the complication in the brain, can cause encephalitis, very important. And in the skin, exfoliation can be troublesome. Next. So all these lesion is very well known. And for the prevention, we must have a strategy. Like other viral disease, you must have a social distancing. All the healthcare workers must protect themselves. So similarly, we have to use the PP kit. So everybody is now aware of how to use the PP kit, how to use the N95 mask. So this is very important in this virus disease, that is monkeypox. And you must have the proper protocol for handling the patients. So this is very, very important, the personal protection, because if any of the healthcare worker, our doctors, our nurses is infected, then it is again a big problem. So we have to be very sure that we use all the protective mechanism while we are handling the cases. Next. So treatment, dear friends, there is no treatment of this DNA virus, but definitely we have the certain drugs trial going on, and there are 2 trials in the USA where they found that cidofovir is very effective, and vaccinia immunoglobulin, VIG, is also very helpful in these patients. Those who are vaccinated for smallpox is protective up to 85 to 90%. So if, because we elderly population have already received the smallpox, but because for last 4 decades, from 1980 onwards, this WHO has given the clear message that smallpox is eradicated all over the world. So no more smallpox vaccination is going on. So younger generation is prone for this monkeypox virus, while elderly population is already vaccinated with the smallpox, so they are protected. So dear friends, we need to learn more about this virus, this disease, and we hope that in coming days, we have the very efficient, very effective vaccine, and a lot of trials are going on, but they are not available in most of the countries. So this one vaccine known as Immunovax is licensed in the USA to prevent monkeypox and smallpox. There are other studies also, but these are the main which is there in the literature search. Next. Thank you. Thank you for your kind attention.
Thank you so much, sir. The two preparing this in a very short span of time, probably in one day you have made such a beautiful slide. which is more concise and helps everyone understand the basics. Thank you so much, sir. Despite your busy schedule, you have done it for us. Thanks a lot, sir. Now, I request Dr. Nilakshi Gupta, ma'am, to educate us on the topic from a microbiologist point of view. Over to you.
Can you please show the slides?
Yes, ma'am. Just a second.
Ma'am, if my slides visible?
Yeah, slides are visible. Next. Sir already mentioned the history part and introduction part, so I'd like to skip that. Yeah, these are the two clades of the monkeypox virus, in which it is divided into West African clade and Congo Basin clade. Basically, these are the two variants of the monkeypox, in which the Congo Basin is more severe and it has more transmissibility rate than West African clade. Previous slide, I would like to discuss the structure of virus, as sir mentioned. Yeah, it is a enveloped virus in which there are three layers: inner membrane, outer membrane, and the surface tubules. These surface tubules, by the help of these surface tubules, the virus attaches, which binds to the protein which are present on the host cell membrane. Then the outer membrane, it fuses with the host cell membrane, which releases the core in the host cell cytoplasm. Then there are the palisade layer, which is made up of protein, which protects the core, which surrounds the membrane. Then there are the two lateral bodies. These lateral bodies act as storage tanks. These store the enzymes which are required by the virus for replication. When in need, the virus utilizes these energy sources, these enzyme sources, for its replication and affecting the host cell membrane. Next. Next. As per WHO data, on 21st May, these are the statistics. But as of 25th May, there are 131 confirmed cases and 106 suspected cases in 19 countries all over the world. Next. This has already been discussed. Next. 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 Sir has very nicely discussed all these slides. So I'm not going in discussion with these slides. I'll start with the laboratory diagnosis for the virus. So the diagnostic samples required are the roof of the fluid or the scab and the dry crust. Then the lesion is swabbed vigorously, inadequate to ensure the viral DNA is collected, and both the types of swabs can be collected, the dry swabs as well as the swabs which are placed in the viral transport medium. Preferably, two lesions of the same type should be collected in the single tube from the different locations of the body. Next. Then all the specimens should be transported like we used to transport our COVID samples, having a triple package, labeling, as well as fully documented demographic details of the patient. Then the specimens should be refrigerated or frozen within an hour of collection, and then they must be transported to the laboratory as soon as possible. If the transport exceeds 7 days, like in case of international transports, it should be stored at -20 degrees Celsius. And the long-term specimen storage, which we require for future references, the storage is done at -70 degrees Celsius. Then presently, only the oropharyngeal swab, skin lesions, like from the lesions of pustules or the vesicles, whatever is the stage of the disease, the skin lesions and oropharyngeal swab are presently recommended as now for diagnosis of monkeypox virus. The other samples are only for the research purposes, and they may be included in future or may not be included in the future for diagnosis purposes. Next. Then the one and only confirmatory test is the PCR test, polymerase chain reaction test, in which the nucleic acid is amplified using the polymerase chain reaction for detection of the sequences of viral DNA. It can be used alone for just diagnosing the infection, or it may be used in combination with the sequencing. PCR protocols are used for detection of orthopox viruses, and more specifically, they also may be used for detection of monkeypox viruses. And as I initially mentioned, the two different clades of monkeypox virus, the Congo Basin and West African clades, can be differentiated. Then only diagnosis can be done in which the monkeypox is present or not is diagnosed, and this is followed by a second step in which sequencing is done to specifically detect the monkeypox virus. And all these sample processing, diagnosis, this waste generated has to be disposed after autoclaving or chemical disinfection, or this I'll maybe discussing in the infection control part of the monkeypox virus, which I'll be discussing in just few seconds. Next. The other methods of diagnosis are electron microscopy, but this method is not routinely used. I have posted a electron microscopy picture of the monkeypox virus. And the second method, which can be used but is not routinely used, is a viral culture, which is not routinely recommended for the diagnosis. Next. Antigen and antibody detections. They may diagnose that you are suffering from a viral infection or variola virus or pox virus, but since the antibodies are cross-reactive to many of the infections, they are not routinely recommended for diagnosis. Then most importantly is the infection control part of the diagnosis and after treatment, how to deal with the patient, his surroundings, the things he has used. I'll be discussing it in under the following heads of isolation of the patient, use of PPE as described by sir also, proper hand hygiene and cleaning procedures which are to be followed, and the household disinfection, which is the most important part to prevent the community spread. Next. In this, the patient suffering from, or if he suspects himself to suffer from monkeypox virus, he should be isolated in a separate room. The other members of the family should maintain a specific distance from him, and they also should avoid the contact with animals, including all the pets and other members of the family, including animals, humans, whatever it may be. Next. Then the person suffering should wear a surgical mask, just like as COVID, to protect ourselves as well as other people to transmit the disease. This holds the same for monkeypox virus, in which the person suffering should wear a surgical mask. He should wear a disposable gloves if he is handling the same surroundings as that of his other family members. He should wear fully covered clothes so that his lesions are covered and the fluid or the vesicular stage, which has a pus or fluid in it, that is not discharged into the surroundings, and the waste which is generated by him is disposed according to the biomedical waste guidelines. Then proper hand hygiene is to be followed. For the persons taking care of the infected person, they should timely do hand hygiene, whether it is hand wash or use of hand rub after coming in contact with the patient as well as his surroundings. Then his clothes and soiled bed sheets and everything are to be washed separately. His utensils are to be washed separately and preferably wearing after gloves, and the contaminated surface cleaning should also take place in order to prevent the spread among other members of the family. Then some precautions are to be taken by the healthcare worker, in which the contact and droplet precautions are to be taken, so that, as sir told us, the modes of transmission of infection are direct transmission and human to human transmission. So in order to stop that human to human transmission, the contact and droplet precautions are to be taken. The PPE is to be worn, and if any aerosol generating procedures are to be done on that patient, the proper protocol is followed, and these all things are to be followed until all the lesions have resolved and a fresh layer of skin has formed on all those lesions which are visible on the skin. Then this vaccination has already been covered by sir, so I'll not like to repeat it. Antiviral agent tecovirimat is developed for smallpox. It works against monkeypox as described by the European Medical Association. They have proven activity against the pox viruses, but no sufficient data is available on the effectiveness of cidofovir and brincidofovir. Next. Then the recommended public health action by Ministry of Health and Family Welfare. The healthcare facilities are, they should diagnose it and keep an eye on the patients who are having a high suspicion of being suffering from monkeypox, like who have traveled in the last 21 days with an endemicity of monkeypox, or they present with an unexplained rash that cannot be classified under the differential diagnosis mentioned by the sir of chickenpox or any other rash. Then if they are in contact with a confirmed case of monkeypox virus, they have to be isolated at healthcare facilities until the lesions have resolved. They have to report at district surveillance officer. All infection control practices which I mentioned earlier are to be followed. Then laboratory samples, whatever the sample is best possible, has to be sent to National Institute of Virology, Pune for testing. And in case a positive case is detected, like we followed contact tracing for COVID virus, similar things are to be followed here. Thank you.
Thank you so much, ma'am, for the wonderful presentation. I would like to request Dr. Major Prachi, ma'am, to give her views about this monkeypox virus from a consultant physician point of view, as well as from an administrator point of view. Ma'am, please unmute yourself.
Thank you, Venkatesh, and thank you, FAIMA, for calling me over here. And thank you, Dr. Suresh. You have given an excellent presentation. And my thing is, I think, mostly over, or Nilakshi has already given most of the part I was supposed to say. I just want to say one thing. There is no, जैसा हम सब लोगों को पता चल चुका है, we don't have any particular treatment for monkeypox. We just have to isolate ourselves. We have to identify. And best part is हमारे देश में rodents को कोई भी नहीं pet animals की तरह से रखता है. And it is only a few certain people. I think there must be less than 1% who keep rodents as their pets, so that we are not supposed to panic over monkeypox. This is my point of view. And most of the time, it is noted that there is no history of travel to the affected countries, and still people are having monkeypox. Maybe they have transported squirrels and all those rodents from the affected country, and which they were like in US, they had gone with the prairie dogs, which are supposed to be like people are keeping them prairie dogs as pets. They had got infection from those dogs and pets. So there is no such thing in our country. So we don't have to panic. But still, people who are coming from the affected countries, we have to take care of them. We have to consider those things. The people who are coming from those countries, they may give us human-to-human transmission. We have to track a contact, and we have to keep an eye over them. If they are having any lesion, they must report. They don't sit at home. जैसे हम लोग COVID में कर रहे थे, we were having infections. We were still sitting at home and doing our home practices and all those individualized treatment. It was there. Self-medication we should not go for, just because we don't know much about the disease. And so we should not, first of all, we should not panic. And it is not going, as far as I'm concerned, it is not going to be a pandemic as far as we are concerned. Till date, it is not going to be a panic. As Dr. Suresh and Nilakshi already told, this is a DNA virus, and DNA viruses are not going to have mutations. So we don't have to panic much, and we don't have any options for viral culture. So we can't say I'm having fever, so I can go for some testing, and I can go for virus isolation, so that I can identify myself to be suffering from my monkeypox. So we have to, if we are having any history of contact with the person who has traveled from the affected countries, we have to isolate. We have to isolate. I feel so. We should isolate. The person should isolate from that for 21 days, as incubation period is 21 days. So we should isolate for 21 days. This is my take. Maybe I'm wrong.
Thank you so much, ma'am. We'll come back to a panel discussion after we listen from our public health expert. Now, I request our public health expert, Dr. Saishta Ali ma'am, to share her views.
Thank you so much, doctor, for inviting me, for being one of the panelists among such reputed doctors. Thank you, Dr. Venkatesh, Dr. Rohan Krishnan. Thank you, FAIMA. So everyone has discussed, I guess, covered all the parts of monkeypox virus. I'll be discussing just about the outbreak at a glance, short view. Since May 2022, cases of monkeypox virus have been reported to WHO from 12 member states that are not endemic for monkeypox virus across the WHO regions. So the epidemiological investigations are going. However, reported cases thus far have no established travel links to endemic areas. So based on the currently available information, cases have mainly but not exclusively been identified amongst SMSM, that is men who have sex with men, seeking care in primary care and sexual health clinics. So the situation is evolving, and WHO expects there will be more cases of monkeypox virus identified as surveillance expands in non-endemic countries. So reported cases thus far have no established travel links, but also the history of people who have traveling somewhere have been reported in the case of monkeypox virus. I'll be discussing about few points like from public health response. Further public health investigations are going on in non-endemic countries that have identified cases, including extensive case finding and contact tracing. Vaccination for monkeypox virus where available is being deployed to manage close contacts such as health workers. So WHO is convening experts to discuss the recommendation on vaccination. Genomic sequencing where available have been undertaken to determine the monkeypox virus clad in this outbreak. Suspected cases, a person of any age presenting in a monkeypox non-endemic country with an unexplained acute rash is there. We have seen this thing. Coming to the description of the outbreak, a short description of outbreak. As of 21 May, 92 lab tests, confirmed lab tests, and 28 suspected cases of monkeypox with investigation going on have been reported to WHO from 12 member states that are not endemic for monkeypox virus. Short review for the epidemiological of the disease that Dr. Suresh has already mentioned about what are the factors affecting and what is actually a monkeypox virus. I'll be discussing a short summarizing it, that everyone knows that it's a viral zoonosis. That is a virus that is transmitted from humans to animals with symptoms very similar to those in the past in smallpox patients, although it is clinically less severe. Monkeypox virus is transmitted from one person to another by close contact with lesions, body fluids, and respiratory droplets, and contaminated materials such as bedding. The incubation period is usually from 6 to 13 days, but can range from 5 to 21 days. Various animal species have been identified to the monkeypox virus. Uncertainty remains on the natural history of the monkeypox virus, and further studies are needed to identify the exact reservoirs and how virus circulation is maintained in nature. Monkeypox virus is usually self-limiting, but may be severe in some individuals, such as children, pregnant women, and person with immune suppression due to the other health conditions. I guess that's all. I have nothing else left to discuss. Sir and ma'am has discussed everything.
Thank you so much, ma'am. So before we continue with the panel discussion, I would request the participants to start asking their questions. We'll take the questions to the panelists. So I would like to ask a first question to our esteemed panelist, Dr. Suresh Kumar, sir. Sir, you being a director of such a big hospital, and probably you might have spent several nights sleepless during the management of COVID crisis. So how do you think you should get yourself prepared for this monkeypox thing? Are you thinking that this is going to cause another pandemic, or how you should keep prepared, and any administrator and the government, how they should see this monkeypox thing?
I think very good question. This COVID has given us many sleepless nights, particularly during the second wave. There are a lot of oxygen problem was there, and we have the 2,000 bedded COVID dedicated facility, and we have treated around 24,000 cases of COVID in the country, highest in any single tertiary care teaching hospital. So with that experience, we hope that we should not have any pandemic in the near future. We are fed up of all these pandemic. All our doctors are doing great work, and they are rather overworked. So we have just recovered from the shock of COVID, but now we are thinking that this may or may not be. But my personal thinking is that this is not going to be a major problem, and this monkeypox pandemic is unlikely. But we, at the same time, we must be prepared. We should not lower our guard down that we think that anytime the situation may change, because if you have the few outbreaks and you have the few cases in the international airport in Delhi and Mumbai, you have a lot of panic, lot of emergency preparedness, and we have to create the facility. We must be prepared. We must have protocol in our place. We must sanitize all our doctors, nurses, healthcare professionals, that if such cases is there in the near future, we must be ready. We must be focused on this. And like we have seen that during COVID, there's a lot of confusion. Nobody knows what to do. Even nobody know how to collect the sample, how to send the sample. So it was a major problem during last 2 years. So this time there are clear-cut guidelines that we must be prepared, but at the same time there should not be any panic. And we hope that there is no further emergence of this monkeypox in our country. We can have some cases, few cases might be reported, because nowadays a lot of international travelers are coming from Africa and from the affected nations. We can't stop the flights. So this is my opinion, that we have to be prepared, but we must not panic.
Thank you, sir. Even I'm from AIIMS Patna, and our HOD is the medical superintendent. So I know how much stress an administrator underwent during this COVID pandemic. So thank you so much, sir, for the great service you are doing to the country. I'd like to request Dr. Rohan Krishnan, sir, the president of FAIMA. Sir, as you know, residents are the backbone of any hospital. And many of these residents have worked very hard during the times of COVID. So from a point of view of a young leader who represents all the junior doctors of the country, how do you see this threat of monkeypox virus?
See, as our esteemed professors and ma'am and microbiologist and public health expert have clearly mentioned that till now, fingers crossed, it's not going to become a pandemic. So let's hope that the resident doctors do not undergo the same trauma again. It's not just the trauma, the physical trauma that they had worked, but it's also the mental trauma of seeing the patients die and not being able to help them. And obviously, Maulana Azad Medical College and Sir himself has done a lot in the COVID pandemic. And we are vouching for him to get the Padma Award as well, as he's already been nominated. And we hope that the government will listen to that. And I personally think that it's not going to become a pandemic. But even if it becomes an endemic in Delhi, it will create a lot of chaos and it will create a lot of panic in the country. We have to understand this aspect as well, because when we talk about pandemics, it's not just that the question is not whether it's going to happen or not. It's usually the question is when it's going to happen. So one must be prepared, and since the Delhi and Mumbai are having a lot of international travelers, and there is a chance that people can transmit the disease from one to another from foreign countries. So it's better to isolate and it's better to protect ourselves than to land up in something which could lead to a slow endemic or a slow pandemic. But let's hope that we don't see those days again for at least a century. Let this be the last thing in our life that we went through, a pandemic, that the COVID be the last pandemic for our lives at least.
Thank you, sir. Thank you so much, sir. Now I'd like to request Dr. Saishta Ali, ma'am. Ma'am, should we be concerned if the first case of monkeypox is reported in our country? So is it a panic situation if one case is reported? In better terms, when should we really be worried? Should we be worried with a single outbreak, or what is the criteria when we should be consider it as a public health problem?
First of all, right now we are blessed that we have not been encountered with such case. So fingers crossed. And the second thing what I would like to say is that we should not panic in any situation. A major concern must be how to deal with the treatment. What are the things that we have, what backups we have got for it? Since we know that this is happening all over the world, so many countries are being affected, we have got that time to get through it. We can get through it. We can get prepared for that thing, for the monkeypox virus. Doctors are, they have got that alarming thing. Everyone is now, they have realized that what is going to happen, what can be happen. So we have got that time. So we don't need to panic in any way.
Okay, ma'am. Thank you. So we have questions from the audience also. Dr. Dheeraj Batra has asked, if 10% fatal, it is dangerous situation for India. What is your comment on it? Dr. Major Prachi ma'am, can you please
Yes,
answer?
the current monkeypox is West African virus. जैसा मीनाक्षी ने भी बोला था, तो उसका fatality rate is 1%. And the virus which is confined to Congo and the Central Africa, uska case fatality rate is 10%. So that recent current endemic is West African virus, so that we don't have to much worry about the fatality rate just because it is only 1%. Although 1% is very high, but still less than 10%. So we should not focus on, as just sir ne bhi bola, we should not panic. So first of all, we should not panic. It is case fatality rate is 10% or so. We should focus on how we can prevent the disease, how we can protect ourselves and not spread. Like we were just initially we were not concerned about the COVID. So COVID say we should learn how to protect the community, how to protect yourself and remain safe.
Okay, thank you, ma'am. Thank you. Dr. Vajjala Sai has asked a question. What is the secondary attack rate, reproductive number, and pandemic potential for this virus? If our Nilakshi ma'am could answer, it will be helpful.
The data on the secondary attack rate and reproductive number has not been yet disclosed by the WHO guidelines. So as and when the data will be available, it will be provided on the WHO or CDC guidelines. There is no data regarding it.
Okay, thank you. Another participant, Dr. Jaymohan Kumar, has asked, should we recommend smallpox vaccine if someone plans to visit the countries affected at present? So can any of the panelists respond to this?
You see, this smallpox vaccine is protective, as it's seen in many of the African countries and in the USA also, that the individual who received the smallpox vaccine, they are protected up to 85%. So 85% protection is seen if they are already vaccinated. And this vaccine, which is available for smallpox, is also protective for this monkeypox virus also. There is definitely advantage of, because they have the similarity, because they share the same group, and the data about whether you have the, because so far we are not using the smallpox vaccine for the prevention of monkeypox, but few countries are using it, and that is protective. Definitely it helps.
Thank you, sir. So in such case,
Sir,
where it will be available in our countries?
Sir, I have a question. I have to say
Yes.
something in context with this vaccine. So I just have a query. With all those inflammation going on with COVID, post-COVID, and antibodies titer are very high. If you go for the antibody titer in patient, any individual, you can find it is around 6,000, 5,000, 4,000. We don't know whether it is because of the COVID infection, natural immunity, or the vaccine-induced immunity. But still, I don't know. I feel so we should think over if we should take the vaccine, smallpox vaccine or not. I don't know. This is my take. How much inflammation monkeypox is going to cause?
Definitely, we need more data, more scientific evidence, and more studies to say that this vaccine, smallpox vaccine, can be recommended in our country, because so far we have not seen it. So we need more information, more data. You are right. When we compare with the COVID situation, that is entirely different, because there are more than 40 or 50 subvariant of COVID, and that is RNA virus mutating every time, which is not seen in this virus, which is a DNS. So this is clear-cut difference between the monkeypox, which is DNA virus, and the COVID, which is RNA virus. So RNA virus treatment is difficult, and mutation is more frequent. Every time you have the new variant. So for that, vaccine is no more effective, and you have to take the booster every time. So which is in the smallpox or in the monkeypox.
So my concern was inflammation, not the virus.
Right.
All those, like we have, people have started reporting with autoimmune diseases post-COVID, and autoimmune diseases are on rise.
No, but even in the Africa, in the Congo and other countries, once you have the monkeypox, it have no recurrence, no case of that. Once you have the monkeypox, you will have in the lifetime again occurrence of the similar disease. It is a lifetime immunity in the smallpox and in the that is
because both are the
lifetime immunity. You have the smallpox, whether by the vaccine or by the natural infection, it remains for lifelong. That is the major difference.
Thank you, sir. Thank you, ma'am. Though sir has clearly told the differences between COVID and monkeypox, we have one question from our participant, Dr. Vajasai. Dr. Vajasai has asked, if in future mixed infection can happen for both COVID and monkeypox, what will be the strategic plan to overcome? Will any of the panelists be able to answer this?
You see, this question is difficult when it's an imaginary situation that you have the COVID and you have the monkeypox. We have seen many patients who have the immunodeficiency like HIV with monkeypox, or other immune deficiencies with monkeypox, or the pregnancy, or the children, or the primary immunodeficiencies with the monkeypox. But the situation like COVID plus monkeypox is not reported so far, because these are the isolated areas where you have the emergence of this virus, that is the monkeypox virus. So this situation, although it can happen, we have seen many hepatitis B and hepatitis C infection. And one is hepatitis C is a RNA virus, and B is a hepatitis B is a B and C co-infection is seen in many patients. Similarly, this type of COVID plus monkeypox can happen, and it can lead to more complication, more severe disease. One virus always triggers another virus. So the disease impact is not the 1 + 1 = 2. It is 1 + 1 is many times. It may be more than 10 times. So the disease severity, case fatality, complications per se, they are much more if you have the two viruses striking at the same time in the same individual. So that is the message.
Thank you, sir. Thanks for such a crystal clear explanation, sir. Due to lack of time, we'll take one last question from the participant, which I feel is a very important question. Dr. Uma Maheshwaran has asked, where does India stand as far as screening of travelers is concerned? Would any of the panelists like to answer?
You see, there's no such guidelines by the Indian government so far. Whatever guidelines are, they are the WHO guidelines. And there's no screening test, no ELISA test that you have the suspected case where there's a facility at the airport and you can diagnose, because mainly it's suspected cases which need to be isolated. If you have there are two clinical features. One is fever, second is skin problem. So if you have a combination of fever plus skin lesion, maculopapular rash with fever with lymphadenopathy, definitely they need to be identified at the port of entry or port of exit. All international airports need to have this type of surveillance mechanism. if they have performa, they give the questionnaire that if you have this, then kindly. But sometimes most of these passengers we have seen in the Omicron variant that you provide the information. They even if you have the fever, they take paracetamol. They write no fever. So that is very difficult to get all the correct information and the correct diagnosis, because diagnosis is very difficult. It's not easy. It is not. We don't have the PCR facility for monkeypox. We need to develop all these protocols. We need to develop labs. The sample right now has to be transported to the NIV Pune, other centers, because in the coming days we can have more information, more guidelines, and national government is very much concerned about all these, and in the coming days we can have some more information on this issue.
Thank you so much.
You are right. If there are rashes, we can identify those cases just because they appear on the face. So at least with rashes, we can identify them and we can say no to, we can stop them to travel. That way, sir is right. History ke saath mein, if people over there are, they can be, they can be made educated how to identify those things, those people who are having rashes, so at least they can be stopped from traveling.
Thank you, ma'am. Thank you so much for valuable inputs. So we are coming to the end of the session. Now I'd like to request the National President of FAIMA, Dr. Rohan Krishnan, sir, to give the vote of thanks.
Thank you, Venkatesh. Thank you, all our esteemed panelists. And it was a very wonderful session. And even I learned a lot. और obviously सर जब पढ़ाते हैं तो थोड़ा सा और वो हो जाता है कि पूरा बेसिक्स भी क्लियर हो जाता है. So it was very nice to have you, sir. And once again, we are vouching for you. Let's see you in the Rashtrapati Bhavan. And thank you, प्राची गर्ग मैम. आप आई यहाँ पर, हम लोगों को टाइम दिया आपने और इतना अच्छा लगा हमें. I also thank Dr. Shaista Ali for coming here and giving us this beautiful explanation about the virus. And also Dr. Nilakshi, जो कि सर आप ही की स्टूडेंट है, मौलाना ज़ादनी सीनियर रेजिडेंट हैं और बहुत मेहनती हैं, हमारे साथ भी पहले काम कर चुकी हैं. So thank you, Dr. Nilakshi, for giving all the members of FAIMA this satiety that it's not going to become a pandemic and we can sleep in peace today. Thank you, everyone. Thank you.
Sorry, Rohan. Sorry. आपको ना ये बोलना चाहिए था, हम नीलाक्षी के साथ काम कर चुके हैं.
Ma'am, it's pleasure for me to have a webinar with you and Suresh sir. This is my first live webinar.
डायरेक्टर वहीं पर बैठा है, उसके बाद ये प्रवचन दे रही है डायरेक्टर के सामने, तो वो डायरेक्टर भी मानता है कि उन चीजों को बिल्कुल ठीक है.
We are learning from sir only.
Yes.
Thank you all for
great
discussion, great and keep it up, and I hope that we have more topics in the near future. So thank you all, FAIMA.
Thank you, sir. Thank you so much, sir.
Thank you very much.
Thank you so much, sir. Once again, I thank Dr. Prachi ma'am, Dr. Shashti ma'am, Dr. Nilakshi Gupta ma'am, Dr. Rohan sir, Dr. Rafia Khan ma'am, and all our wonderful 250 plus participants for making this webinar a grand success. Hope the knowledge gained out of this would have cleared most of your doubts. The e-certificates for this webinar will be sent within a week's time, and the recording also will be available in FAIMA's social media handles. Thank you so much, everyone. We are closing now.
Bye. Stay safe.
Thank you, sir. Thank you all. So we are closing.
Thank you all. Thank you, FAIMA.